SLE is an important disease from exam point of view. 90% it occurs in female and the peak age of presentation is 20 to 30 years. Next is the pathophysiology. We have two components, one is the genetic and other is the immunologic. So genetic component first. Okay, higher concordance in monozygotic twins. Here this monozygotic twins that indicate that there is genetic contribution, and the higher concordance means that there is not complete concordance, which means that environmental influence is also present. Okay, next is the polymorphic variants at HLA locus. The people with HLA-DR2 and HLA-DR3, they are more prone towards SLE. Next is the mutations in complement components, mostly C1q, C2, and C4, and the immunoglobulin receptor Fc, gamma, R3b. They are mostly expressed on the neutrophils. Mutation in these also make the person predisposes the person towards the SLE. Next is our DNA exonuclease, that is TREX1. DNA that persists in circulation, it is removed by this enzyme. Okay, so if there is mutation in this enzyme, then the DNA that is present in the circulation is not removed, it's going to persist in circulation. As a result, the immune system sees them as foreign and development of double-stranded DNA antibodies that make the person sick. Okay, next is our immunologic component. So antibodies versus antigen within the cell, the antigens that are within the cell or the nucleus. So defects in apoptosis or in the clearance of apoptotic cells, there will be inappropriate exposure of intracellular antigens, and as a result there will be polyclonal B and T cell activation and autoantibody production. Next, very important, that are the clinical features. So let's deal with the first one, that is arthritis. 90% it is present. Early morning stiffness is present, tenosynovitis, and joint deformity may also occur. Next is the Raynaud phenomenon. It can present with arthralgia or arthritis, and if it is severe, digital ulceration can also occur, and is mostly secondary. So these parameters they focuses that it's secondary, not the primary one, like the is male greater than 25 years old and no family history. Next is the skin. Yes, there is classical facial rash, the butterfly rash. The rash can be discoid in shape, diffuse, arterial eruption can also occur, or livedo radicularis. Next is the kidney. So the patient may present with proliferative glomerulonephritis, hematuria, proteinuria, and cause on urine microscopy. Next is the serious problems. Okay, there can be pericarditis, myocarditis, and endocarditis. Accumulation of heart valves of sterile fibrin containing vegetations. So next is the involvement of lungs. So there can be pleuritic pain, that is serositis, and pleural effusion, pneumonitis, atelectasis, pulmonary fibrosis, and reduced lung volume can also be present. Next are the neurological symptoms. So fatigue, headache, and poor concentration, visual hallucination, chorea, transverse myelitis, organic psychosis can also be present. Next are the hematological. So lymphopenia, neutropenia, thrombocytopenia, and hemolytic anemia. Okay, now pediatric disease. Okay, so renal and cutaneous, they mostly occur in the juvenile SLE, whereas the remaining ones, they mostly occur in the adult. So now let's deal with the investigations. Okay, so in order to diagnose a patient that he's having SLE, the clinical features with this dot that are present on them should be present, like arthritis, rash, this butterfly rash, okay, discoid rash, photosensitivity, serositis, kidney disease. Here proteinuria is very important. Next is the organic psychosis, seizures, mouth ulcers. Yes, we have missed these one, like the gastrointestinal features that are present in SLE. Peritoneal serositis, mesenteric vasculitis, and the hematological problems are also included here. So next are the labs. So we are going to investigate for the ANAs, antibodies to ENA, anti-double-stranded DNA antibodies, routine hematology that includes our CBC, biochemistry, that includes our LFTs, RFTs. Next is urine analysis that is also done, C3 levels, they are also checked, and the ESR will be raised. There will be leukopenia and lymphopenia. Next is the management in case of mild to moderate disease in which only skin and joint problems are present. Analgesics, NSAIDs, and hydroxychloroquine are given. Whereas in case of pleurisy or pericarditis, glucocorticoids along with the immunosuppressants are given. In case of severe and life-threatening disease, high doses of glucocorticoid and immunosuppressants are given. In maintenance, prednisolone, azathioprine, methotrexate, and mycophenolic acid mofetil are also given. So that's all about SLE. If you like this video, click on the like button, and thanks for watching this video.